So we will move to the lower extremities. Okay. Good. What are the recommendations for to do something in addition to Doppler ultrasound? Of course, Doppler ultrasound is the first late image method. This is a clear consensus from the guidelines. But in addition, there are some indication if you exactly have to know anatomical structure in lesions, in particular if you plan a revascularization strategy and if you plan a discussion of the cases, for example, in your vascular board. And this is the indication to perform an imaging. Well, the most patients, we discussed it already, will profit from MR imaging because we have no radiation, we have better protection if you have kidney insufficiency in these patients. So we bring with you and discuss on the different cases MRI images, and in addition, in which cases we should add maybe a CT scan to add additional information. I bring to you first one patient. He's 61 years old, have a chronic wound in the left heel, Rutherford stage 6, a typical diabetic patient, but maybe not so typical. Please see first the MRI scan of the aorta and the iliac artery. What do you see? So please, maybe one of you can say, do you see any problem already on this image? It runs a little bit fast. I know we cannot stop it.
The issue is we cannot stop it. This is the only way we
Maybe we go to the next image, so you can see the problem a little bit clearer. So we have here you can see there is a long occlusion and a short occlusion on the other side. So the left superficial femoral artery is occluded. The right is also occluded, it's true. But we have the problem on the left side. Would you treat both sides, or would you decide to treat only the left side? Who will decide to treat the left side first? Nearly everybody, I think so. Well, it depends on the patient. Mostly we have to do something for the wound to heal, and this would be a treatment of the superficial artery on the left side. But to have a total image, we also have to need the information for the lower limbs. So we will have a look on the next image. Here you have the lower limb. And not typically for this diabetic patient, we have 3 arteries on the lower limb. So the main problem, of course, is the superficial artery, and I add the lower limbs. So the main problem is, in this case, the superficial artery. When we discuss this case in the board, what treatment strategies do you have in this case? Is exercise an option? No, because of the wound, it's not an option. You have to revascularize. I go back. I hope it is possible to go back to the upper leg. So, no, one more back. What are our therapeutic options in this case?
So we want to clarify. In such a patient who, the patient is showing up at your institution with a wound on the heel, is a diabetic patient. So what would be the first approach? You would do an ABI, you would do an duplex ultrasound, and just for planning the procedure, we need some other additional imaging. So who has the ability to do an MRI, a CTA, or who is already going quite immediately into an angiogram, into an angiography? Duplex ultrasound only. MRI.
We have it already in this
Yeah.
case, of course.
CTA. This patient you have to have in mind is a patient who has Rutherford 6, diabetes. So what might be the issue why you should not go into CTA, although it's the easier procedure because it's 6 minutes compared to whatever 45 minutes or 10 minutes compared to 45 minutes. The patient has a wound, maybe has issues with laying on the table during the MRI procedure. What might be the issue? Just thinking of doing an MRI before a CTA scan.
Can I make a comment?
Yeah.
This is a limb-threatening situation.
Yes.
And so what I need, I'm an interventional cardiologist, is just the approach I have to use to revascularize this patient. So I think that you have the indication to revascularize the patient. If the Doppler ultrasounds tells me that I can enter anterogrally in that leg, I don't care about other things. I mean, the occlusions above or below the knee, because I will see what I have to do when I enter.
Maybe you can answer that. But you will perform an invasive strategy if you have, in addition, an occlusion of the popliteal artery, of the lower limb arteries. You do an invasive procedure in a patient with diabetes with a high probability of renal insufficiency, and you give them contrast media, you make a puncture of the artery. I think it's the better approach, and this is what we say in the guideline, to discuss such a long lesion with the surgeon and to discuss whether to perform bypass surgery or endovascular treatment in this case.
So because there is one thing I want to step in. We have only one trial out there which is really comparing bypass versus endovascular. And in critical lymphedemic patients, it's the basal study. And in critical lymphedemia, the bypass, and this would be maybe a candidate for a bypass if he has the veins, because he has a very good runoff, has a better outcome. So therefore, one thing, it always depends from the situation you have in your institution. But I think we should not promote here just go in and do what we see. But I think we should make a planning for a plan for our patient.
Remember that if you perform, for example, I have a very poor MRI facility, so I should do a CT scan. But if I do a CT scan with contrast media, and then I decide that's better to do an angiography, I can make an overload of contrast media in this patient, although I can use CO2 angiography, for example.
Of course. But in this case, we had the possibility to get a fast MRI scan, and we discussed the patient in our conference. And we did an intervention in this case because our surgeons say try first to do an intervention, but in agreement with our surgeons. So it's very important to discuss it. I think we should, if we have the possibility, go with the guidelines.
Yeah, luckily for these patients, this one is a typical diabetic patient.
Yes.
Usually we have, that's one. And we had to estimate below the knee distal lesions because of the runoff.
Yeah.
So it's crucial to have the information about this.
Right. And
especially for the surgery, for the endovascular, for the patency of the graft, and all of these things. So we need it. Actually.
The problem of Doppler's ultrascan in this patient is the flow below after the occlusion is slower. And it's not so easy in a patient with diabetes, and in this case with medial sclerosis, to see in a very clear direction the lower limb arteries and to make decisions. It's my experience in this case. And then it is, if you have the possibility, in this case you can also use the anti-carotid approach to perform an intervention because you have left a long enough segment of the superficial artery. But I think it's a nice case to be discussed in this case, and we did it, and I think you might discuss other decision, but I think this was, for this patient, the right decision.
And one principle for CTA compared to MRI, especially in patients with critical limb-threatening ischemia, is the outflow. So you have a better insight with the MRI than compared with the CTA. Mirel? Mirel?
Usually our surgeons don't like MRI because they want to see the calcifications.
That's-
And they
that's-
prefer
yes.
CT scan.
That's true, but you do not have an insight in the outflow. So this is the outflow is very poor in CTA, in CTA angiography. I know this calcification issue. That's a topic in every discussion. At the end, this is not the relevant one. It's more relevant to see how the outflow is, because if you have bad outflow, the graft or whatever fails. You can do both if you are very. This is not
Yeah,
appropriate for the patient, and it's very expensive, I would say.
And you can say something about the calcification by
Also on
ultrasound.
MRI,
By
or
ultrasound.
and you can look at the source images. So you have different ways of looking at it, and I would not underestimate, once again, the primary screening tool, which is ultrasound. The primary screening tool is ultrasound. So if you go down there and see all this calcification, and then you do the additional, this is just compare it. You want to go to whatever. We want to go to from here back to our hotel. Okay, you have you see somewhere how to go, but then you need the exact Google map how to go there. And this is just for mapping, and the ultrasound is just for getting the, and Christine also, the decision, Christine has also pointed it out, it's also about hemodynamics. So we should not forget about that.
All patients we perform MRI have previously the decision that we want to do something.
Yeah.
Now, only in these cases we
left.
perform additional imaging.
I completely agree with Marianne. The MRI is far better for below the knee lesions. And I need time to convince my surgeons, but nowadays they accepted it. But I need time, couple of years. But nowadays with these techniques and MRIs for below the knee lesions, it's excellent.
Okay.
It's
So-
comparable to standard angiography.
And maybe you need somebody who makes you a good MRI scan. Not everybody makes the same quality of images. All images I have brought to you are from an outpatient radiology, different outpatient radiology practice. And they have had to learn it, because we have to tell them what we want to see. Now they make, I think, very nice images. So maybe we discuss the next case. So I brought you. What have you done? Well, we did a revascularization. We discussed it with endovascular revascularization, and yes, what you said previously, what we went the way up through the guideline. The second patient. This patient is 72 years old, has a claudication of the whole left leg, was a smoker, has high lipid levels, arterial hypertension, and as you can see, he has different problems. He has an aortic aneurysm, he has here stenosis, as you can see, and one thing I want to show here is the point that you cannot see, for example, the whole amount of the aneurysm. You have first, from my point of view, to add an ultrasonographic evaluation. Of course, we had this before we performed the MRI, but just sometimes the patient bring his images with you. This is important. And in addition, maybe we can discuss, in this case, in fact, about additional CT scan, Marianne.
So who would go for back just to do a sonography, and who would do a CT scan? So who would do a sonography?
Sonography, we have already done the sonography.
Yeah, but just to add the final lumen, just to give the surgeon an insight, and what will also be better for the follow-up. So, does anyone want to comment on that?
We are performing usually sonography for follow-up. Yeah. For some follow-up, yeah.
Yeah.
Who would do it the same way, just sonography? Raise your hands. Okay, so that's the majority. And CT scan?
For the follow-up of the aneurysm, depending of the treatment, after treatment, or because if I see if it's 5.2 centimeters, 52 millimeters. Yeah. So for the follow-up, depending of surgery or endovascular prosthetic, right?
I think, oh, Victor.
It's in line with what Tristan says, because we have three kind of follow-up. Follow-up of a small aneurysm before reaching the size for any intervention, which is maybe too late here because we have a 52 millimeters. But then you have the follow-up of patients who have been have endografts, or patients who have been operated. So the follow-up is not the same, and even the imaging method that you would use wouldn't be. May I just stress that we have also to think about the radiation of these patients who have multiple images, and we don't know what is the cancer risk of all these things that we are doing nowadays.
And this is one thing, I guess, we should really, because these are patients who are coming back, these are patients who are coming back with a lot of different morphologies of the vessels, and we do radiation once and once over again, and we do not take care of radiation. We do take care of radiation in the cath lab, but not with follow-up and imaging procedures. So I think this is a very, very good argument for low radiation approach.
But we have also to look for the rest of the patient. Maybe he has some additional problems, and he has. On the other leg, he has a long occlusion. Now, we can discuss whether to perform, besides the iliac lesion on the other side and the aortic aneurysm, if we have only this, to perform on a primary invasive approach. But if I show you the next slide, you can nicely see that it's not the only problem in this patient. So in this patient, he was sent to our hospital from a vascular specialist, from another vascular specialist. He told us, please treat beside the aneurysm, which was an additional result, but please treat the iliac artery on the left side and leave the right leg. We plan to train it because this is a very complex situation. I think you can always discuss the perform intervention, but in this case, you can also discuss a conservative first approach because you have a Rutherford stage 3 patient.
Who is not in line with that? Because I hear some murmurs in the audience.
I would do iliac artery besides the aorta.
Yes, of course. The iliac artery only, and the other side we would plan to train.
And I think one argument, we have seen it quite nicely, are the good and thick collaterals on the right side. So if we have done and fixed the left one, maybe the patient will be not having a lifestyle-limiting claudication or not a severe claudication, and he might go for exercise training.
Yeah. Would you do an intervention in this case? Of course. On the right leg? Left leg is clear. Is clear. The right side? No? Oh, okay.
I should do the left iliac and then see for the patient. I think that an exercise program could be enough. You will have right claudication after treating the left leg, but we can see the patient later. I don't think we can revascularize endovascularly the right leg. And so I just in case of need, I think the surgeon can do a femoral, tibial or femoral fempop bypass.
But not in stage 3, I think so. Yeah.
Yeah,
the AAA must
this
be
this is something
first.
else. This is first. We are the AAA. It's not. Yeah.
Of course. We have to treat first the AAA.
Yeah.
Of course, it was a discussion besides the AAA.
It
Did-
was a discussion besides the AAA.
Right. What would you do with the legs without the AAA? First, you have to treat the AAA, and then you have to discuss the rest, of course. It was an occasional finding in this setting.
The point is that if you have the AAA, you also fix the iliac.
Of course. For example, it's suitable to treat, and we can plan treatment with MRI only in this case. So we have a third patient, a younger one, 51 years, Rutherford stage 3 again, both sides, heavy smoker. So it's on the first slide, you can see the main problem on the right side. You see here an occlusion of the total iliac artery. And what do? We discussed it in our board. What's the problem?
Would you leave it with this kind of image, or just, say, okay, I need a CT scan for that? This is a patient, 51 years old, so he is showing up the first time. We can be sure if we do some kind of treatment or not any kind of treatment, just exercise training, he will show up once and once again. So he might get, if you are too aggressive with this highly radiation imaging like CT scans, I think we do not any good thing to this kind of patients. And with regard to revascularization?
We discussed it with our surgeons.
Just stop smoking first and read you later.
Yes, of course.
Because it's Rutherford stage 3, we do not know how long he has had this claudication. So maybe after some exercise training he gets some improvement.
Yeah, I agree. What's the ankle brachial index?
The ABI was 0.5 on this
0.5?
leg, yes, and the patient has very problems to do his work. That's a problem.
0.5 is low. For the 50-year-old man.
I think, from my point of view, it's not so successful in such an occlusion of the iliac artery to be successful with any conservative treatment. It's often don't work.
A comment about revascularization. At least in my area, surgeons do not perform a bypass in a patient of this without trying to revascularize endovascular this patient. At least in my area.
Okay,
so
but
I don't know.
we discussed exactly this point with our surgeons. Our surgeons say, why do you show us these images? Just do a revascularization. But I, from my point of view, see two problems with this. I have to go, we are very close to the common femoral artery. And if you perform revascularization, for example, from the crossover approach or the brachial approach, you have a landing zone with a high probability within the femoral artery. You can try it. But if you get subintimal and you have to stent the common femoral artery in a patient 51 years old who moves, who is active, it might be a problem, isn't it? Yes. Yes, we have a moving segment in the common femoral artery, and therefore we try to avoid any stenting in this moving segment, because stents can break in this segment. We can also have problems with flexible stents, such as the superior stent, because this stent can have acute occlusions if the patient is sitting for a longer time, and therefore I discussed this very hardly with our surgeons, not to avoid stenting in this area. When we perform a revascularization and we are in the subintimal channel of the vessel, we have to re-enter the lumen, and then it might be too late to down in the common femoral artery. Yes.
Just when I see a patient of 51 years old with such a lesion, my fear goes to the heart and the cerebral vessels, not to the leg. Yeah, but it's really important. In intermittent claudication patients, only a minority will have a critical limb ischemia later. Most of them, if you try to control the risk factors, stop smoking, keep walking, they won't lose the leg. But if you go for multiple revascularization, we know that sometimes the outcomes is the occlusion of the revascularization and the amputation. But here I don't know why he has a left side claudication, and I will try to look if he has a stenosis of the external iliac artery, and then maybe I will discuss with a surgeon after controlling the risk factors for aortic femoral bypass, because the patency is much higher than other revascularization.
Else location explaining this problem, and I think in this particular case you could discuss whether you want to add some additional imaging. I think in this case you can discuss it. In the duplex ultrasound, we did not see a lesion in the contralateral iliac artery. We didn't see it, and the external iliac artery looks a little bit hazy in the MRI scan. We looked for this in duplex scan, but we didn't find anything. The only finding we found was this problem.
Yeah. Sometimes you need a workout before. For the iliac arteries, with the ultrasound, you need to little workout or exercise to depict stenosis. So did you perform the duplex ultrasound after exercise, for example?
No, we performed the ultrasound at rest, and we also performed, of course, a treatment test of the patient. The problem of the patient is that he cannot walk anymore. He is working in transportation of things, so of packages and so, and he cannot work at the moment. That's the main problem for us. But we are absolutely right. We have to check the coronary arteries in this patient because it is high probability to have a coronary artery disease.
Just a brief comment. I fully agree with you that going from the contralateral femora would be very risky in terms of re-entering the true lumen before the origin of the common femoral, because you see there is the epigastric artery there. So what I would do, as the patient clearly needs some treatment because he's really impaired in his daily life, I would try to go from below, from a retrograde recanalization, and see if I can get into the common iliac. Because otherwise, from above...
But maybe you might, anyway, also need a stent in this area.
So
maybe.
Just to conclude this, because I think it shows that it's really difficult.
No, I cannot stop it.
We have a young patient with Rutherford 3 with lifestyle-limiting claudication. I'm an interventionologist and I'm very keen to do endovascular procedures, but I would stop my young fellows at that point because what we see here, the patient has very tiny vessels. He is still smoking, and if you really do, you can do everything. You can always produce a fancy image afterwards. But I would guess that this patient will show up with restenosis at a very early stage. So even if it is not able to work, I would recommend the approach for Milena first. Stop smoking, medication, and wait at least 1 to 2 months because he has a nice collateral over there, how he's improving. Okay? Yeah, Elena?
I've got a question for you. Do you revascularize patients that are still smoking?
No. You know, the issue is we should not do it, but they say, okay, we have stopped smoking, and then you see them after the successful procedure, they are walking down with their wheelchair, whatever, to the smoking place. This is really a difficult topic. So we have to go on.
Yeah. So the next patient.
Sorry, what have you done in the end?
We the patient will come again. We have not did anything at the moment. We decided that the patient come back to us to talk about the discussion in the board and about the images, and we will discuss with him conservative treatment versus surgical approach. We will discuss it with him. That was the final decision that he comes again to us. We did not treat him yet. It was 2 weeks ago, the MRI scan.
And do you think it depends on whether you have a good rehabilitation program or not?
Well, I think, of course, it is very important to have a good rehabilitation program, but most patients joining exercise training groups are quite older, because this is a very young patient. Most patients in our groups are 65 years older, and the patient has really a problem with his to save his work. So that's the main problem, and maybe exercise training takes too long time for him. So I think he will finally get revascularization, but you have to stop smoking, of course, and you have to keep exercise in addition after this. Yes.
So the next case is there? Sorry. Oh, sure, Lucia.
Just one question, a practical question. I understand that it's very important to gather a team together with
Yes.
the interventionist, the surgeon, because taking such a decision on going on conservative treatment after 1 or 2 months, the patient comes back, but maybe. Most of the doctors, at the moment when they see such a lesion, they say, wow, hey, we have to do something, you know. And if you decide, go home, let's do the conservative treatment, the rehabilitation program, maybe after 2 months, someone comes back to you and blames you because you didn't do something earlier. So it's very important to understand that
Yes.
to gather all the people
Right.
and take the decision with all of them.
You are totally right. We also have a draft after each decision and discussion of the patient, and it's much more acceptable for every physician outside of our board because it's a board decision. So we have each week this board at Wednesdays, and we have an additional board for the carotid arteries at Tuesdays. So we discuss these patients all in a board. So I think it's more acceptable also for the patient when we say to them, we discussed it in a board, it's difficult to perform it endovascular, maybe you have to train. The patient accepts it better if we say it's a decision from multiple experts.
So
Can
one
I-
last question from Lucia.
It's just a comment. I don't think age should be a limitation to suggest a patient to go on a rehabilitation program because the beneficial effect is there. The earlier you take, the more you have. We have a lot of young patients, also non-atherosclerotic disease patients, and actually they do benefit more than the older ones. The important thing is that in this program, there is kind of a personalized approach, and the pace in which they walk is more. They should not get bored. But when you have a younger patient who walks more, it's actually driving momentum also for the older ones that walk less. And we saw that the interaction,
Yes.
a mixed interaction within a group is good. So to the young doctors, don't choose for your patient, propose the good things to everybody, then discuss
Of
and
course.
be really propositive.
Thank you for this point, Lucia. It was maybe a misunderstanding. Of course, I totally agree we have to do exercise training programs for every patient. But this patient is frightened to lose his work. That's the problem.
So,
Yes,
Yeah.
the patient has, of course. No, of course. It's a very important point.
so this is the last case because we're running out of time.
It's the last case, in fact. So this patient has Rutherford stage 3, again, intermittent claudication of the left side. And as you can see, at the right side, he has already a treatment. And he has a treatment, a TEA of the common femoral artery and a profunda patch. He's still smoking, unfortunately. It's a major problem. And you see here nicely the patch, and the problem on the other side is very similar. So this is a typical case with a common femoral artery lesion. And this patient, we would discuss with the surgeon to perform surgery to avoid stenting again in this very mobile segment. But we have to know what is in the next sides of the leg, because maybe we need a hybrid procedure with the operation of the groin and in addition an intervention of, for example, the superficial femoral artery if we decide to do anything or not conservative. So the next moment.
He had already
yes.
Yeah,
but as you can see here, we have in addition, and we see it also in ultrasound, additional lesions in the superficial femoral artery. So we discussed in our board a hybrid procedure to perform operation of the groin, and in the same procedure an intervention of the superficial femoral artery. But you have to go forward in the patient. The lower leg is okay.
So this, I mean, the main issue if you have this stenosis of the femoral artery is the degree of calcification, and if you see in duplex ultrasound that he has a very cornerstone calcification here, I would maybe follow a Murray's approach to go for a CT scan just to see how calcified the vessels in the pelvic region and the below the knee regions are, so that the vascular surgeons could have a better approach for what they are doing. And you also see the runoff in a sufficient way in this kind of patient, because this is
the next one.
No, the further one is a Rutherford 3 patient and has smoking and hypertension, so might not have lower limb disease. So this would maybe a patient just to go for duplex ultrasound, CT scan, just to see how calcified the patient is. And this is the really only thing, the whole calcification of the leg, can be better detected by a CT scan than MRI. This is just really the indication. Or if they have a pacemaker, if they cannot lie in, or if they have a phobia, just to get into this really tight MRI machines. These are or metal implants like hip or knee prosthesis or whatever. So these are indications for CT scan, and especially the degree of calcification, as Muriel has pointed out. So the last case,
this show this problem. And as an example, you can see a patient, Rutherford stage 4, rest pain of the left side, smoking, diabetes, and the patient, you don't know exactly what happens here, because he has an endoprothesis of the knee with a metal artifact. Therefore, and that's very, very important for our fellows. Please ask always the patient if they have any metal prosthesis of the knee, of the hip. It's very important to, because in this case, duplex ultrasound is superior in this area to the MRI scan. You can only face this artery segment nicely with duplex scan, and if you perform, for example, an angiogram, it depends on the prosthesis. It might be also problematic to see the popliteal artery in a whole. So please do first duplex artery scan and ask your patient about any additional metal artifacts possible in the artery. And the last case, I want to show this nicely case because you have fantastic collaterals of the profundal artery. This patient already started training. He's not the ideal candidate because of comorbidities. She has to stop smoking, and she promised me that now she will stop smoking, and we could motivate her to go further with training. In this patient, of course, I do not see the indication to perform MRI scan, but she brought the images with her when he came to us first, and we recommend her to do an exercise training program because of the excellent profunda collaterals. So I want to summarize the pros and cons. The visibility of the exact structures with MRI, it is non-invasive, planning for vascularization procedures, no radiation, contrast media without iodine. But it's expensive, it is technically complex, you don't do it yourself, you have to need somebody else. Therefore, please do first duplex ultrasound. You see so many things with this. You have contraindications. Some patients cannot go to the scan. Some pacemaker devices have problems. Also, some lens of the eye. You must ask your patient about this. Metal artifacts, stents, joints, metal splitters, and some patients you find sometimes something surprising when you ask for metal splitters. Several kidney insufficiency it can be a problem because of nephrogenic systemic sclerosis, a very, very seldom complication. Thank you for your attention.